Hi, everybody. It's good to see you all. Welcome to our November Leaders in Public Health series. I am absolutely delighted to welcome Dr. Dena Bravata to our series today. For those who don't know her, Dr. Bravata is a healthcare entrepreneur, executive, and scientist. She's the co-founder of Lyra Health, where she also served as Chief Medical Officer. She was the founding Chief Medical Officer and Head of Products at Castlight Health twice, from 2008 to 14 and again 2019 to 22. And most recently, she served as co-founder of Lyra Health, a company that's using AI for mental health and palliative care. Dr. Bravata was a practicing internist for 16 years, as well as an attending physician at Stanford University and the Palo Alto VA. And she's a nationally recognized health services researcher. Dr. Bravata has published widely on the clinical effectiveness of a variety of key health technology, clinical, and public health topics, and has served as an inspiring mentor and force behind many of the health services researchers that some of us recognize as amongst the most influential in the field today. I met her through her position on the Aspen Health Strategy Group, for which she's a founding member. They meet on a yearly basis to take on big topics of importance to the health of folks across the United States as well as across the globe. She's been incredibly influential in the way that they think about that work, as well as in their yearly reports. She's also served as an assistant public health officer for Santa Clara County and currently serves on the board of several health services, technology, and services companies. I will say that I frequently like to highlight folks' connections, and Dr. Bravata was a Yale undergrad, so we are quite happy to welcome her back to her old stomping grounds. Her MD is from Columbia, so we share that in common, and her MS is in health policy from Stanford. She also has a twin sister who directed the RWJ Clinical Scholars Program for many, many years, so has a lot of deep ties both to our community and to public health in general. So with that, Dr. Bravata, Dena, welcome, and truly thank you for coming back and joining us. It's an absolute delight to get to spend time with you.
Thank you so much. It has been so fun, even just before the conversation, so spending the day here has been great so far. Thank you.
Sure. Well, I thought that we'd get started with a question that I ask many of our leaders in public health, which is to share a bit about your journey, right? So to situate people, some may have read up on your bio, some may not have, but I think thinking about kind of how you went from being a baby physician and public health professional to your current world where you're working in the startup world, health tech, health innovation. Can you share a little bit about kind of how you got from there to here?
Yeah, thank you. First, people often ask me like, well, did you plan this? Yeah. And let me demystify that out of the gate. So my journey has been one purely of great good fortune and serendipity more than any planfulness. So I think like many clinicians, so I did the standard kind of academic gig you shared where I had my training. And I loved being at Stanford. So I was there for 16 years. I was in the health policy, health economics group. I did health services research. And because I was more of a methodologist as opposed to having like one clinical area, I got to work on lots of different projects. And I did a variety of technology assessments. And you talked a little bit about public health work that I did. And I think that I just, I am a primary care doc by training. I'm interested in a lot of different clinical domains and mental health. We'll talk more about mental health later. But I care about cancer as much as I do about mental health in lots of ways. And when I was a junior faculty member, I had the chance to kind of dabble and do little side projects here and there. And I didn't even know what it meant to be a product manager for a technology company. But I was asked to help develop a product feature for an early innovation, really, that enabled patients to provide information to their clinicians. And so I helped them do that in a structured way so that clinicians could make triage decisions about that information. And I kind of liked doing that. And one of my mentors was Alan Garber, who
now president of Harvard. So, she chose clearly well. Yeah.
And Alan was friendly with a set of healthcare entrepreneurs, and they were starting Castlight at a time when I was kind of at an inflection point in my academic career. And so I left the clinical practice of medicine, which I loved, and I left my academic world and all of my grants and mentees to be the founding chief medical officer for Castlight. And so I haven't seen patients in a long time, but that then kind of launched the subsequent journey in healthcare entrepreneurship, but still being very much rooted in academics and in kind of thinking the way that academics tend to think about innovation.
Thank you. So it's inspiring and I think really helpful to maybe some of our students who are like, well, what's the next thing that I need to do? And a takeaway often is the best thing that you need to do is to be really good at your methods and at your work. And as you shine, you'll find opportunities that you may never have even imagined. I mean, when you started your career, who would have thought?
By no means.
Yeah. We didn't have smartphones when our.
No.
So a lot of your work has been in the mental health space, and you just alluded to this. Lyra Health in particular has been an incredible leader. I wondered if you would mind speaking a little bit about kind of what drew you to that work, and also share with the community who may not be familiar a little bit about Lyra, Brightline,
sure.
Castlight.
Yeah, so I think like, most Americans statistically, I have family members who have suffered from serious mental illness. And so I think that has always been in the background for me. As a primary care doc, you cannot avoid taking care of people's depression, anxiety, sleep disorders, substance use disorders. And so it was something that throughout my life as a clinician was important to me. I was an attending at the VA, and I think there, obviously there's a lot of very effective mental health related treatment. So I saw some best practices in play there. When I was at Castlight, so Castlight, for those of you who don't know, was a really early digital health intervention. It was launched commercially in 2010 and provided it's a technology that was provided through commercial health benefits. So employees had access to this tool through their health benefits, and it enabled them to see what services would cost them, what services were made available to them through their health benefits. And I was the chief medical officer there and head of products. I also ran the analytics team. And one of the things that I saw in our work doing analytics was the unrecognized economic and mortality burden of mental illness for these employee populations. So when I would talk to benefit leaders of these innovative companies around the United States that were providing Castlight to their populations, I could see that their populations with diabetes who also had comorbid depression were costing them 4 or 5-fold what risk adjusted that same diabetic population would be costing them. And I think that was not really that well understood at the time. And so I was eager, as I was thinking about what I would do after Castlight. Castlight was a technology company at that point without a services offering. So I had 2 things that I wanted to do. One was to do something that was at the intersection of technology plus services. And I was really motivated by this problem, that at that point was not really that well understood for mental health, especially for commercially insured populations. And so that led to the founding of Lyra. My co-founder, David Ebersman, is a wonderful man, and he was on the board of Castlight. And so we started Lyra in January of 2015. So it's we're coming up on the 10-year anniversary.
Wow.
And in full disclosure, I have not been involved in the day-to-day of Lyra for many years. it's in his very capable hands. And Lyra serves the same population, so commercially insured populations. It's a benefit provided through their employee-sponsored benefits, and it provides a full range of mental health services, from digital interventions, so digital cognitive behavioral psychotherapy and other related tools, telehealth related, so people can get psychotherapy or see a provider virtually, or they can get matched to a provider in person.
I love it. As you talk about this journey, one of the things that strikes me is kind of the way that we often think about innovation and care delivery within academia is a little different, perhaps, from how you've learned to think about it in the startup, and now no longer startup, but actually quite stable company space. Mm-hmm. How has your thinking about kind of innovation and care delivery shifted over this past decade plus of working outside of academia in actual service provision?
Yeah, so I think that one of the things that is most notable about sort of both of these environments is that fundamentally patients and providers, right, like that dyad is where the magic happens. And I don't think it really matters that much if that's happening in a large academic hospital or if it's happening virtually. Like ultimately, when it's services between patients and providers, I think that it is relatively similar. That said, I think that in a tech-enabled world, right, we have the opportunity to implement services, to use technology to really evaluate those in much, much more rapid fire. I think that we have the opportunity to recruit clinicians who want to be part of innovating their clinical domain. And so there's this spirit of let's do our best work, let's evaluate that, let's iterate on that in a way that I think is certainly like the mindset in large academic medical centers, but just may not move at quite the same pace.
NIH grants don't always facilitate that type of pace or that type of real flexibility.
Yeah. And may lack the fundamental infrastructure for doing that ongoing quality assessment. Right.
Well, and I think that's actually one of the really neat things about the work that you've done. So I will say, in full disclosure, I hired one of Dena's former PhD students at Brown as one of my last hires before I left, not knowing that he had been her PhD student until we were chatting. But I think that one of the neat things about what you've done is that you've kind of merged that all the strengths of industry with also some of the rigor and evaluative capacity of academia. Maybe you can talk a little bit about that, particularly for some of the students and or faculty in the audience who may be interested in those types of partnerships.
Yes.
Especially as we're looking at a world where NIH funding may be a little more uncertain, and we're all thinking about kind of how do we continue to do great, impactful work. I think that you've set up some really neat examples of doing impactful work through partnership.
Yeah, so the gentleman to whom Megan is referring is Chris Whaley. He is a PhD health economist now at Brown. And Chris, I think, is a perfect example of this. So at Castlight, we had been around for about 3 years, and so we had developed a sufficiently large, in this case, claims repository to really be able to do some innovative analytic work. Chris was getting his PhD at Berkeley at the time, and he used that data set to really begin to understand if you have a benefit design that is there to incentivize particular health utilization behaviors, and that is coupled with a technology that enables people to understand the choices that are available to them. He asked questions about how do those two worlds interact, and what are the health economic outcomes of having benefit design plus transparency tools. Chris then went on, so he got a PhD on that. He then went on to RAND, and we, by being friends, continued to collaborate as we have for the last decade plus. And so I think that our relationship is just this perfect example of people in the private sector have access to amazing data sets about, be they claims or what are the kinds of health services and technologies that patients are interacting with, what ones are they not interacting with, how do we think about the effects on health or outcomes or mortality or whatever the outcome of interest may be. And many commercial entities don't have like a dorky academic co-founder, and lack somebody with the methodologic experience to be able to rigorously evaluate those products and services. And the buyers of these technologies and services are becoming increasingly sophisticated, right? And so, can they tell the difference between a, propensity match cohort that somebody did a nice job on versus not, probably not, right? I don't know that I could these days anymore either, but there's a greater and greater obligation on the part of private sector companies that are delivering health services to demonstrate in peer-reviewed or other methodologically rigorous ways, does their product work as they say? For whom does it work? For whom doesn't it? And part of that is really then accretive to their brand by saying, look, we are thought leaders in whatever the clinical domain may be.
If we, for example, had faculty or students who were interested in that type of partnership, how does one go about it?
Yeah, I think this is a perfect forum for that. So
one of the reasons that we have people like you here, but it's
Yeah. So I think there are research. So if someone is interested in dipping their toe in the water, but they don't really have a bunch of pals who are in the startup world, I would say that some of the clinical research organizations whose job it is to actually do this work for hire are great places to do that. But to the extent that you do have this network of, in this case, Yale alums or so who are out in the real world, I think just having these kinds of conversations, right? So I work with many companies, and one of the things that I do with them is to help them design their evaluations. And sometimes those evaluations are not for public consumption. They're for them to understand how well are their tools and services working, right? Are they living up to, are they fulfilling their promise just to themselves? And then obviously there's the marketing benefit that can accrue as well.
And I'll say there, for those in the audience or on Zoom who are interested, if this is something that you're interested in, certainly reach out to me. We have a whole office through Yale Ventures that helps with these corporate partnerships to structure them in a way that when you're going into it, whether or not it's for pay or for experience, to know whether or not you are allowed to, to say a priori, yes, I'm going to publish, no, I'm not. Is it that you're doing you have a contract to do some stuff on behalf of the company that's going to stay private? Yeah. Or is it a real intellectual partnership and that you're co-creating together? Which I think is important to set out those terms from the get-go is really helpful.
That's right. And and there are SBIR grants. There are granting mechanisms that are a little bit more academic-y leaning, right? So where as students, as faculty members, you are co-investigators with the product folks on the other side. And I have worked on some of those grants that have just gone beautifully, and some that did not go quite as well. And I think the thing that characterizes the best of these is a very clear understanding of what exactly are we going to evaluate, and depending upon if the outcomes are good, bad, or indifferent with respect to showing the product or service offering in the best light, what will we do with respect to publication? Because if you have a junior faculty member, right, they need those publications for their tenure track and the like, and yet for marketing purposes, that could be devastating, especially for a young company. I think also the timelines need to be very well understood, so that if you're getting a grant and it's over a year or 2 years or whatever, and the company in the meantime is pivoted and gone off in some totally different direction, that can be really not so great.
Yeah, that can be, and the timelines just between having been part of a couple of SBIRs and STTRs, the timeline of the startup, right, is often very different from my timeline. Like, well, I want to have the perfect study design, and they're like, I have 9 months, right? Like the phase one grants are super, super short, and so thinking about how we can maybe approximate truth rather than approaching perfection, which I know is a big hot debate in the world right now about kind of, how perfect do you have to be in the data that you're collecting and in the estimates that you're creating. So that leads me into a different, there are kind of two other big things that I want to get to before I open it up to the group, and I'm going to set them both out. One is talking about quantitative science today. The other is thinking about the future of public health. And I know you sit on a bunch of boards and have including some food as medicine work, and so have some interesting thoughts there. So let me take the first one, but I want to just highlight for those in the audience that I will get to the second as well. So I'm going to kind of disclose vulnerability here. So I had lunch with Dena a little over a year ago, and I had not yet started this job. And she said to me, as I'm talking about kind of what schools of public health should be focusing on, she's like, you should not be graduating anyone who doesn't have a strong quantitative data science skill set. And if she could, anything as you're looking at kind of School of Public Health graduates, that is something that is distinguishing, and as a top school, we should have that. And I kind of took that into my brain and thought, I really need to talk to her more about what she means, but I don't have a plan yet, and I don't know the school well enough yet to be able to come back. So it took me a year to go back to you, but that comment stuck with me. And as we've been starting to do our work in our school around our strategic plan, right, we have our priority around kind of data science and AI and data equity. It's something that I would love now that I'm in a slightly different space for you to share some of your thoughts about what you meant by that and where you see the future of kind of public health data science going before I get to that topical future of public health, but kind of within the data science world, kind of what you're seeing as the rapid changing landscape, but also what you meant by a rigorous quantity. Like, what would you want our students or some of us as faculty who may wish we could go back and take some courses, what do you see as kind of those areas that we need to lean into?
Well, first of all, I mean, like, if anybody has done an awesome job in a year, right? Like, I mean, seriously, I could not be more impressed and delighted and like proud as an alum to be affiliated with all that work that you've done.
Thank you, Dena.
What I meant by that at the time was that I had so I did my my postdoctoral training at Stanford, as you heard, and I was in a very methodologically rigorous environment, right? So I'm not a health economist, but I was surrounded by them.
You had Jay Bhattacharya down the hall. Yes.
And a lot of the work that I did was in meta-analysis, systematic reviews, regression-based prediction modeling, and that kind of thing. And I had a number of colleagues, very, very smart colleagues, thoughtful people who were public health graduates, not of this institution. And what I noticed about the distinction between our training was that they were great at thinking about populations and setting policies in nuanced ways that would be appropriate for this or that clinical situation. But what I came out of my training with was like very pragmatic, useful skills that I could then apply in a set of situations to then go on to inform, be it a policy or a product design or that kind of thing. And I saw, like, at least for me, how very useful, like, being able to do a regression or do some data science was for my own career. And so that was a lot of the motivator. I think also, when I looked at hiring people, right? So the very first people that I hired in my first role outside of academics were people who were trained like me. And, and I think that that's sort of like a human foible maybe anyway, but what I found was that clinicians who were health services researchers somehow, like, they had this data-driven approach that enabled them to work better with the engineers than other clinicians who were a little perhaps more risk averse and couldn't use the data to help shape their intuition about product design in quite as facile a way somehow. And so again, I saw that there, and that's, I think, part of the answer to your question, like in terms of what I look for when I'm hiring people. I think by and large, especially on like the clinical product strategy side, we have data. We should use it to inform those kinds of decisions.
Yeah. And then you and I relatedly have had a lot of discussions about AI and the challenges of teaching in kind of this world where AI is both advancing faster than we can create a syllabus, but also changing the way to the students in the audience, right? The way that you study, the way that you learn, the way that you do projects. And we've had you have a colleague who recently went back to get an MS in AI and ethics?
Yes.
Is that, yeah.
Yeah.
So, and from your side, from the business side, I'm sure there's no way you're not having discussion of that. So I'd love your thoughts about kind of what we need to be learning about AI or teaching. And learning. Those of us that are faculty are learning sometimes along with the students.
Yeah. So I would say, outside of the academic environment, so among innovators, among entrepreneurs, I think among venture capitalists, private equity firms that are making investments in technology, the intersection of AI and healthcare is absolutely the greatest area of buzz. I'd love to talk maybe a little bit about GLP-1s and obesity care.
Sure, we can do that too.
As well, but like I would say that those are probably like the two sexiest, most interesting topics right now. I would,
along with palliative care.
Yeah.
But yes, go ahead.
And so you mentioned Solara, which is a startup that's working in the space of using AI to help deliver protocolized, so highly evidence-based psychotherapy for populations who don't have access to it today. And I think it's pretty easy for us to imagine, right? Computers, we've had digital versions of CBT for 2 decades. Right? So all right, like let's add a little flavor of AI to that. That can make it a little more personalized, perhaps a little more empathic. But I think the magic actually comes beyond that. So the magic actually can come in and actually, like now, having the technology summarize clinical notes so that when you see this patient for the next time, or you're a new provider who's never seen this patient before, right? Like you would never go through and read all those therapy notes. And here is a nice summary of where they are and what kinds of very personalized bits of information might be most motivating for that patient. I think some other uses for it that are very compelling are in training and recruiting and training. So let's say you're the chair of the Department of Psych and you want to hire somebody who's good at doing psychotherapy, right? Like, let's see it do it, and and not with a vulnerable patient, but with an AI patient, and let's see if they say anything that might raise a red flag, or perhaps they're good at it, but not that efficient. It took them like a really long time to get to it. So maybe you can have assessments along whatever criteria are important to you. From a quality point of view, and we talked about this a little bit with some folks this morning. So as somebody who has been responsible for clinical teams, it's a little foam.
It's on your. There we go.
Okay. Whoops.
Oh, yeah, it's fine. The thing's still on.
I think we're good.
We're good.
From a quality assurance point of view, so at many times in my past life, I have had to listen to interactions between nurses or doctors and patients, or had to do chart review or that kind of thing. And then usually, it's this sort of exhausting, cringe-worthy experience where you then have to think about a way to thoughtfully provide feedback to your colleague in a way that's going to resonate with them so that they can do a better job next time. And and even if you do it every week like you're supposed to, maybe you can do 1 or 2% of all patient encounters, which always just leaves me like sleepless at the thought of like, well, what am I not seeing? What am I not hearing about? And now these tools can do quality assurance on 100% of patient interactions. They can do so with objective criteria and provide feedback to the teams as a team in a useful way and to individuals in a useful way with very specific learning for those individuals. I really think that the quality lift that we should expect that of these technologies.
Any of us that develop interventions and do intervention trials can imagine that fidelity component of the intervention just gets transformed. And then from an implementation science perspective too, you think about, right, like how many studies do we have, and I'll look at Susan Bush here, but like how many studies do we have showing that provision of care does not follow quality guidelines? What if you could use this? But then there are equity concerns on the other side, right? So if the training database is not representative, what if those objective criteria are deeply biased? And you've been doing some thinking about that as well.
Yeah, I mean, and I look to your colleagues here as folks who will advance this. I think that I at least applaud the efforts on the part of many machine learning experts to recognize that if their training sets are biased, so too will their outcomes be. And I think this is really important when we think about this concept of looking for digital twins. I don't for some of these AI-based tools that are really trying to predict future events, so to predict future high-cost events or preventable ED visits or hospitalizations, one of the methods by which they do that is to look at a large collection of related patients, pick a digital twin of the patient that we're trying to understand what their what the future might hold for them. And if that large collection, if the training set doesn't include vulnerable populations, low-income populations of color, and so on, we're never going to be able to do an accurate job in our predictions. And so there are then, I think, very interesting and creative computer science techniques for improving that, which are well beyond my pay grade.
But which I'm grateful that we have some faculty here that are working on, which is super cool. Okay, so you mentioned GLP-1s, and then we've also talked about, so there's this real tension, and we talk about this frequently, right, between GLP-1s, which are magical in many ways, but then also the structural factors. And particularly, we were talking last night at dinner about kind of looking forwards, having some concerns about states that are eliminating free lunches for kids during the summer, for example. So kind of how are you thinking about GLP-1s? You said you think they're magical, but then how do you balance that with kind of that attention to the structural or kind of more classic population or public health side of things?
Yeah. So for me, I think that GLP-1s are one of the most important health innovations of my career, and they are also incredibly costly and have low availability to some of the most vulnerable populations who need them. I think critically, I have spent most of my kind of post-academic career thinking about commercially insured populations, and so here, every employer in America covers GLP-1s. And for those of you, right, just to be clear, these are the Ozempic-like drugs that have been FDA approved for diabetes for a very long time. So every company covers them for that, by and large. And so the question now is, now that there have been expansions for these meds for weight loss, and if you estimate that 40% of the adult population in the United States is overweight or obese and maybe a candidate for them, this could just like wipe out the expenditures on health benefits. Like, no more musculoskeletal care, no more cancer care, right? We're just going to spend all of our dollars on this, which some people sort of think like is okay because if we can eradicate the obesity epidemic, that then cancer rates will fall, as will many other issues. I'm not so sure I would go that far, but nevertheless, I do think that it is very important to think about ways that we can increase access to these really important services. And so we are at a crossroads when it comes to commercial entities thinking about about this. So among small employers, so those are employers with less than 1,000 employees, about 5% covered GLP-1s for weight loss in this calendar year. I think that number is estimated to go up. I see estimations between sort of 12 and 25%. So we'll see. I don't think it'll be anywhere near 25%. And there are also concerns that if employers choose to cover compounded versions, so not the branded versions of these drugs, that they may get into trouble, right? That the rebates that they get from drug companies may go away. So I think there is a lot of complexity to this. These compounded drugs, especially when they're made thoughtfully in compounding pharmacies that are compounding chemotherapeutic agents, and like these are excellent facilities, right? That offers an affordable option to large populations that otherwise would not have access to these drugs. So the reason I think it's so interesting is because of the power of the powerful effectiveness of these, the huge size of the populations, no pun intended, who might benefit from them, and the enormous, right, cost-effective kind of concerns.
And the short-term versus long-term cost effectiveness, and then all these other things that now they're saying, well, GLP-1s may also be effective for treating addiction, right? So some really interesting questions, and as we go back to that mental health space. Well, for my final question before I open it up to the audience, as you think kind of about the future of places like this school, are there things that you see on the horizon, right? You sit on a bunch of boards in addition to being, part-time often, well, you live in Wyoming, but so then part-time in the Bay Area. As you kind of work in this mix of people that are thinking about the future, what is the kind of space of the future that you would say to us is 5 years ahead, or things that others aren't thinking about yet that you would want to see us lean into?
Mm-hmm. Well, I think, as I reviewed the strategic vision that you set for the school, I think you have done a beautiful job I don't really like that.
I didn't plant that, by the way, at all. So that was not thank you.
I mean that with all sincerity. I really don't like this term future-proofing. I think that there is no such thing. But like, you have been thoughtful about, training the future generation to think independently, to use the best tools that are available, recognizing that those tools are advancing at a pace that outstrips our historical ways of even creating a curriculum, right? Like, I would be so daunted if I sat in the shoes of people who are teaching today and thought about, like, okay, what do I want to teach 12 weeks from now? It's like, oh my God, well, the large language models will have evolved exponentially by then. So maybe I'll just leave that part of the syllabus open, right? And
our education committee will love that.
But I do think that it is about these ideas of ethics, considerations around diversity and vulnerable populations, keeping our eye out for those. There has been a technological divide forever, and I can't imagine that these newer technologies are not just going to exacerbate that. What is our role in terms of, like, is that just going to be like one more public health problem, or how can we all, kind of make sure that is less likely to happen?
Thank you. We'll take that. As I look around the audience, and I know some of you that are online, I know that we have many folks that are stepping into that space, and I'm excited to report back to you as we continue to make progress. All right, I will open it up for questions both in person and on Zoom. As always, we will pay attention to the chat in addition to welcoming questions from the in-person audience. And if you don't mind just introducing yourself and your role in the school to give Dena a sense of who she's speaking with. We'll do a trade-off. Technology, our best friend and our worst enemy.
Does this work?
Yes.
Yeah.
Okay. My name is Shelby. I'm one of the data scientists under Dr. Mukherjee. We're a new team doing data science and data equity. So while I was doing my master's at Johns Hopkins, I did a consulting project with med-track students in neurobiology, and we did such a project on mental health. Like, it was a company that was seeking to do extra clinical mental health diagnoses. And in premise, the idea of being able to like create an AI that was able to do that was technology that's been around for decades, really, the ability to do such things. But where we ran into difficulties was with the ethics of it. And you mentioned doing like mental health, and it sounds like it's within the auspices of like a hospital and under like direct supervision of a physician. But I was wondering how you navigate those challenges, especially as people outside of the clinic are looking to do some of these things.
Yeah. So Shelby, like that is I think the fundamental question that I bring to my thinking about Solara in this case, so. We were talking last night at dinner. You hear about in the early days of ChatGPT, for example, someone expressing suicidal ideation, and it may pose a question along the lines of like, I'm thinking of hanging myself. What are your thoughts? What do I do? And actually, it provides guidance. Right, like the opposite of what you would want it to do, right? Perhaps like direct someone to a national cancer suicide hotline or something like that. Instead, it like gives you, can even provide diagrams for how best to do that. So that is right. So obviously, in a modern approach, right, it's all about setting up a set of constraints so that could almost like you try to have the probability of that ever happening go to zero. And I think that is around this novel science of prompt engineering and really around thinking about what is the corpus of information upon which these large language models are being trained. But I think that anybody who is in the world of trying to develop these technologies, right? Like that's the worst thing.
And you mentioned last night that was it 9 million people are using GPT right now for?
No, we were talking about a different.
Was it
that
Replica?
was Replica.
Okay.
Yeah, and so Replica, for those of you who may not be familiar, is a personal companion where people have personal companions for many reasons, and sometimes for emotional comfort. And so this is a company that has that technology, and I think that I was surprised as I began to learn about this world, about the prevalence of the use of just, sort of non-healthcare, non-academic types of interventions that are being extremely widely used by people who have loneliness, low-grade depression, anxiety, and so on.
And I think that's part of the ethics question. It's also, right, is this more harmful than nothing, right? And so how do you start to like tease out those risks versus benefits? And I think I'll say risk versus benefits is a core question for us as a field in everything, as we saw with COVID response, right? Like thinking about and actually quantifying what are the potential harms as well as what's the potential benefit, and how do you put your finger on the scale? And there's cost, there's individual outcomes, there's societal outcomes, there may be outcomes that are not health related as well. And I think it's a deep area. For those who are interested, we do have a digital ethics center here at Yale. One of our grads is actually serving as one of their inaugural staff. And so it's a good place to work with, and obviously also have bioethicists on our staff, on our faculty. So we have a question in the back.
Yeah, so to continue in the vein of what you were just discussing, and maybe getting you to speculate
Introduce
a little.
yourself, please, Jason.
I'm Jason Hockenberry,
Yeah.
professor of health policy, and I do work in behavioral health policy. How far away do you think we are from CBT, so cognitive behavioral therapy, like well-validated therapy being delivered by AI?
Oh, we are there. It's here. Yeah. So, I mean, I think I think maybe from a regulatory perspective, right? Are there digital CBT, right? So there are digital CBT tools that are FDA approved for standalone psychotherapy, and they've been around for a long time. I think like perhaps sort of the second level question that you're asking is, well, how about today, right? Will we let these AI-based tools loose on populations without any human in the loop? And so, the tool, I would love for you to play with the Solara tool. There are others, right? They're extremely good. They are true to the protocol in empathic ways. Patients can interact with them in the middle of the night or during the day. They can have, like long sessions and short sessions, things that would never be feasible, even with some of the like best asynchronous models. But the question will be, when will they be FDA approved for delivery and for reimbursement without a human in the loop? And I would say that we're extremely close to that.
And there, I will say, I'll just put in a plug. We have Michelle Tarver, who's the director of the FDA Center on Digital Health and Diagnostics, who's going to be joining us in February, I think, for one of these lectures. So ask the question. Yes.
We have some good Zoom questions, so I'm going to jump into a
Go for
Zoom
it.
one.
Zoom, and then Susan, I saw your hand. So
this is from Christine, who's a visiting PhD student. She asks, how do you look at the balance between using more resources on giving people access to weight-reducing medication versus using the resources on public health interventions which prevent the development of overweight and obese conditions? There's some large ethical issues about giving medication to up to 50% of the population.
Mm-hmm. Yeah, I mean, so I think that this question about prevention versus treatment is, fundamental to our entire healthcare system. So I would say, we don't have infinite resources. We need to do both. But there are people who are having the deleterious effects of being overweight or obese today, and it's incumbent upon us to do something for them every bit as much as we should do prevention.
And you work on you work on food insecurity as well, which I just to point out, like as we think about obesity, right, that it's about food insecurity as much as it is about right. Mm-hmm. It's people who are food insecure are more likely to eat ultra processed foods because they are cheaper.
Yeah.
Yeah.
Yeah, I work with a Connecticut-based company, Nourished RX, which is in the food as medicine space and is really trying to deliver. So they take care of patients who are at the intersection of food insecurity and some medical condition that requires them to be on a healthy diet. So diabetes, hypertension, high-risk pregnancy, obesity, and I think it's very interesting to see the advances in the payment models for these kinds of interventions. And I think it's a little bit of a misnomer. One of the things that I've really learned from the Nourished RX team is that, giving people food is a great thing. I like to feed my friends and family. But that's really just like kind of a hook.
Yeah.
To getting this population, this vulnerable population, to engage, to learn about healthier foods, to learn about where to access them, to learn more about nutrition science, what's appropriate for them and culturally relevant for their families. And so this isn't just about like giving people food for the rest of their lives.
And on my list as a post follow-up is to connect you. We have a team in our Office of Public Health Practice that does a fair amount of work in the state of Connecticut around food as medicine. It would be fun to connect you guys. So I'll do that after. Yes, Susan.
Hi, I'm Susan Bush, and I teach in the Department of Health Policy and Management. And I've done a lot of work on behavioral health. That's most of my main area of interest. So one thing I'm really interested in is workforce shortages in mental health. As you know, this is a huge problem. And I've really been engaged in thinking, like, how can we address it? And it's a really, really tough problem. So I've attended a lot of webinars, say in the past 6 months, national academies, national council, just to hear different people's ideas. And there really aren't that many really like ideas that are really going to take us very far on these websites. I was on these webinars. I was on a webinar just yesterday, and the big idea being floated, I think this was national academies actually, was let's require Medicare and Medicaid to pay for psychotherapy at cost. And that's a proposal apparently right now. And to me, that's like a non-starter. You can talk about that. I just don't think that's going to happen. And it's particularly not going to happen, with the new administration. That's in my opinion. Maybe I'm wrong there. And I noticed that there were at least two things that you mentioned that could really address the workforce shortage. And I'll just call everything you just said about AI, like improving the quality of psychotherapy. potentially this could be shorter duration for people when they go into psychotherapy, and that could potentially relieve some pressure from the workforce. Also with Lyra, I did take the opportunity to go on the website. There's a really nice study that suggests if you have an EAP that works really well, very robust EAP, Lyra, you can reduce your mental health costs. And I assume a lot of that is through labor, so that would also potentially relieve some of the pressure, even though I understand the EAP does have some mental health workforce within that intervention. So can you talk a little bit about what this disconnect is? I'm sitting here so excited about what you're seeing, and then I go on the webinars and I'm not excited. Like, they're not talking to each other. And I will say, I've even talked to industry folk, and I remember I sat on a call with ABHW, the sort of lobbying group for the behavioral health insurers. Have you thought about, in terms of provider networks, we were talking about mental health provider networks and how you could have a more adequate network. Have you thought about maybe EAP, like really developing your EAP as a way to do this? And like, people looked at me like I was crazy. Like, they had never even, it's almost like this had never occurred to them. So if you could speak to that, I'd appreciate it.
Yeah, you're asking just an amazing question. And I think that the answer is sort of yes, all of the above, right? So I think, I am a primary care doc. Primary care docs have a real role to play in increasing access to mental health services, right? I was not at all trained. I was never trained in motivational interviewing or CBT or anything like that. My poor patients suffered as a result, and, would have been good if I had gotten a little bit of that along the way. Maybe a tool to help primary care docs like me begin to be able to deliver a bit more psychotherapeutic interventions inside of primary care, I think could be useful, but that has to come with reimbursement as well. I think that AI, right, like this is the reason for Solara, right, and for other companies like that, right, we have got to address this access problem. Can technology do it? I think in some cases it can. Can technology support like lower levels of trained individuals to deliver this in safe and effective ways? I absolutely think that it can as well. But EAPs and I think of those as different ways of reimbursing, right? Like classical, sort of delivery mechanisms. And so we need to have innovation in who is paying for what. Collaborative care is an intervention that some of you may not be familiar with, which is basically where you have expert mental health providers doing sort of population level mental health, and then providing guidance to often master's level social workers, psychotherapists, in some cases primary care providers, to actually deliver the intervention. And it has been studied in well over 100 randomized controlled trials published in very fancy journals that demonstrate its effectiveness for lots and lots of populations, and yet it's almost always only been deployed in kind of
low income,
federally qualified health centers, or in European countries that have socialized healthcare systems. And so and when you ask why, often the answer is because of reimbursement, right? Because we have not incentivized in a fee-for-service environment those providers to actually take that guidance, and especially, right, like if back to me as a primary care doc, if someone said, well, Mr. Smith, for whom you take enormous care about his diabetes and hypertension, right, like what he really needs from you is a little Seroquel or some other fancy drug that an atypical antipsychotic that I really don't feel comfortable writing for that. If you feel so comfortable writing for that, why don't you feel free to do that? But that's of course not how that kind of model works. And so I think I would love to see regulatory and financial mechanisms that would incentivize more of that kind of program that would increase access, I think, enormously.
And I think, I know we have a couple of hands. Just to kind of add on to that I think that this is an incredible opportunity for us as a school, as we think through, as we're thinking through our new federal administration and where there may be opportunities to do good for populations. I think there is going to be a willingness to look at models of payment and of care delivery that are different. And so thinking about kind of what sort of alliances we can build with people like Dena, with kind of behavioral health work, right? How can we create those alliances now so that we're ready to propose things that have data behind them and could be transformative for the American public? So we had a question back there, and Mike and Joan, and that'll probably be our last, just for the sake of time. We'll do lightning round now for the last couple minutes.
All right, no pressure. Mike Hansberger, I'm the Director of Academic Affairs, and I spend a lot of time thinking about how we can make our curriculum more authentic, preparing our students for the workforce that they're going to be very soon thrust into. And so you mentioned quantitative skills as something we should really kind of hone in on. I heard you. I'm assuming just learning the mechanics of a regression is not sufficient. So what are the missing pieces between learning the mechanics of the quantitative skills and using them effectively in the workforce to kind of be the foundation of data-driven decision making?
Yeah, it's a great question, and I think that it depends on the person and the role that they're going to fulfill. So shockingly, I still do analytic work from time to time.
Really?
Yeah, oddly enough.
Awesome.
And partially because I love it and that kind of thing, but and partially because I'll sometimes work with a company that, like, my rusty skills are better than like whatever else might be available in-house. But by and large, for somebody like me, like, I should not be, like, doing that kind of work, but I should be able to understand it well enough to ask the analyst, right, like, why did you choose those sets of variables, or did you consider this or that kind of thing? And I think that for someone else who's actually the data scientist, right, like, the very best of those folks with whom I work, usually, right, like, I'll ask for, like, oh, okay, let's try to predict this or understand the relationship between these variables or whatever, and they'll do whatever I suggested, but then they'll come back usually and say, like, well, yeah, so I did that, but I did this too, this thing that you didn't ask for, which is obviously, like, vastly cleverer and leads to the most interesting and relevant outcome. And so it's for that person, they really have to understand the method, but then also the clinical domain in which they are working. And so I think the answer is really very much a role dependent one. But I think you have to have done it enough to, right, like, to have the ability to ask questions, because otherwise these technologies are moving so quickly that it's easy to get intimidated and be like, oh, okay, well, there are, like, a lot of numbers on this page, and I'm not so sure that I'm going to question you. You seem like a smart person.
Well, with that, and I know that I'd promised Joan the last question, but I am conscious of the time, and many people have to get to meetings and class. I'd love to give a big round of applause to Dr. Bravata. I am so grateful.
Thank you all.
And Yale is proud of you,
Thank you.
And in good Yale fashion, we do have swag, because, you can't come here without it. She'll be sticking around for a little bit. Feel free to ask questions, and look forward to partnerships for years to come. So thank you, Dena.
Thank you all.
Thank you, my friend.